Question 1. Which of the following is a significant reason for questioning the phenotype of bipolar disorder in youth? Is it A, discrete mood episodes in prepubertal children, B, continuous irritability and mood dysregulation, C, lack of ADHD symptoms, or D, low frequency of aggressive behavior? The answer is B, continuous irritability and mood dysregulation. So why is this the correct answer? Well, bipolar disorder typically presents with distinct episodes of mood changes like periods of high energy and euphoria, followed by periods of depression. These episodes are quite clear-cut and have defining beginnings and endings. However, in young people, especially children and adolescents, bipolar disorder can sometimes show up differently. Instead of these discrete mood episodes, they might exhibit a more continuous pattern of irritability and mood swings. It's not as clear-cut as the classic manic depressive cycle seen in adults. So when you see a young patient showing constant irritability and mood dysregulation without those clear episodes of mania or depression, it raises a red flag. It makes you question whether this is truly bipolar disorder or if there is something else going on. The incorrect answers were A, C, and D. Let's touch on those. So option A, that talks about discrete mood episodes in prepubertal children. While this can be a feature of bipolar disorder in adults, it is not necessarily the primary reason for questioning the phenotype in youth. Then option C, that mentions the lack of ADHD symptoms. While ADHD and bipolar disorder can sometimes coexist or share similar symptoms, the absence of ADHD symptoms alone wouldn't be a significant reason to question the phenotype of bipolar disorder in youth. And then lastly, option D, that talks about the low frequency of aggressive behavior. Aggression can be a symptom of bipolar disorder, especially during manic episodes, but its frequency alone wouldn't be the primary factor for questioning the phenotype. Question 2. What is a challenge in diagnosing bipolar disorder in children with a history of severe ADHD? Is it A, lack of irritability, B, discrete mood episodes, C, lack of distractibility, D, complicated diagnostic process? The answer is D, a complicated diagnostic process. So when diagnosing any mental health condition in children, it can be tricky, but when you add a severe ADHD into the mix, it becomes even more challenging. ADHD itself can have overlapping symptoms with bipolar disorder, like impulsivity, hyperactivity, and inattention. So trying to tease apart which symptoms are due to ADHD and which might indicate bipolar disorder requires a careful and thorough evaluation. Moreover, children with ADHD may already be receiving treatment and support for their symptoms, which can further complicate the picture. The medications used to treat ADHD, like stimulants, can sometimes mask symptoms of bipolar disorder or even exacerbate them. So when you're dealing with a child with a history of severe ADHD, you're trying to determine if bipolar disorder is also in the mix. It's not just a straightforward process of checking off symptoms. Let's go over the incorrect options, A, B, and C. So with option A, that talked about the lack of irritability. While irritability can be a symptom of both ADHD and bipolar disorder, the absence of irritability wouldn't necessarily be the primary challenge in diagnosing bipolar disorder in children with severe ADHD. And option B mentions discrete mood episodes. While this can indeed be a challenge in diagnosing bipolar disorder in children, it's not specifically related to the co-occurrence of severe ADHD. And then option C, again, this one's talking about the distractibility of symptoms of ADHD. Its presence of or absence alone wouldn't be the primary challenge in diagnosing bipolar disorder in this context. Question 3. What percentage of children with bipolar disorder, not otherwise specified, developed bipolar 1 or bipolar 2 illness over a follow-up period of 5 years? Is it A, 10%, B, 25%, C, 45%, or D, 60%? The answer is C, 45%. Well, bipolar disorder, not otherwise specified, NOS, refers to cases where the symptoms don't fit neatly into the category of bipolar 1 or 2. So when you have children who are initially diagnosed with bipolar disorder, NOS, there's a certain level of uncertainty about how their condition will evolve over time. While they continue to exhibit symptoms consistent with NOS, or will they eventually meet the criteria of bipolar 1 or 2 disorder? The fact that 45% of children with bipolar disorder, NOS, ended up developing either bipolar 1 or 2 illness over a 5-year period highlights the dynamic nature of this disorder and the importance of ongoing monitoring and reassessment. It also underscores the need for flexibility in diagnosing and treatment planning, as a child's presentation and trajectory may change over time. Question 4. What typically precedes a classic manic episode in adults and older adolescents with bipolar disorder? Is it A, hypersomnia, B, psychomotor agitation, C, major depressive episodes, or D, psychotic features? The correct answer is C, major depressive disorder. So, bipolar disorder is characterized by alternating periods of depression and mania, or hypomania in bipolar 2. A major depressive episode often precedes a panic episode in what's known as classic bipolar cycle. During a major depressive episode, individuals may experience persistent feelings of sadness, hopelessness, loss of interest or pleasure in activities, changes in appetite or weight, sleep disturbances, fatigue, feeling of worthlessness or guilt, and difficulty concentrating. It is a low mood phase that can be quite debilitating. Following a major depressive episode, some individuals with bipolar disorder may then transition to a manic episode. Mania is characterized by elevated, expansive, or irritable mood, decreased energy or activity, decreased need for sleep, racing thoughts, grandiosity, impulsivity, and sometimes psychotic features like hallucinations or delusions. So the key takeaway here is that a major depressive episode often is severe as a precursor to classic manic episodes in adults and older adolescents with bipolar disorder. It's part of the cyclic nature of the disorder, where the periods of depression are followed by periods of elevated mood and energy. The correct answers were A, B, and D. Option A, that suggests hypersomnia. Option B suggests psychomotor agitation. And then option D suggests psychotic features. While these symptoms can occur during manic episodes, they typically don't precede the onset of mania in the same way that a major depressive episode does. Question 5. What is a characteristic feature of classic manic episodes in adolescence? Is it A, intermittent irritability, B, lack of reality testing impairment, C, grandiose delusions, or D, psychomotor retardation? The answer is C, grandiose delusions. Now, why is that? Well, when someone experiences a manic episodes, their mood is typically elevated, expansive, or irritable. Alongside this, they may exhibit a range of symptoms include increased energy, decreased need for sleep, racing thoughts, and impulsivity. One of the hallmark features of a manic episodes, especially in adolescence, is the presence of grandiose delusions. These are false beliefs about oneself or one's ability that are exaggerated or unrealistic. For example, a teenager experiencing a manic episode might believe that they have special powers, talents, or abilities beyond what is realistically possible. They might believe that they are destined for greatness, have a special connection to important figures, or possesses extraordinary skills. These grandiose delusions can be quite striking and often stand out as a key feature of the manic episode. They can also have significant implications for the individual behavior and functioning during this period. The incorrect answers were A, B, and D. Option A suggests intermittent irritability. Option B suggests that the lack of testing impairment, and option D suggests psychomotor retardation. While irritability can indeed be a symptom of manic episode, it's not necessarily the characteristic feature in adolescents. Lack of reality testing impairment is also not an accurate description. Individuals experiencing manic episodes often have impaired reality testing, meaning that they have difficulty distinguishing between what's real and what's not, especially when it comes to their grandiose beliefs. And then psychomotor retardation, on the other hand, that refers to slowing down of physical movements and is commonly associated with depressive episodes rather than manic. Question 6. Which of the following psychotic features is commonly associated with adolescent manic episodes? Is it A, social withdrawal, B, persecutory delusions, C, apathy, or D, hypersomnia? The answer is B, hypersomnia. And why is that? Well, during a manic episode, adolescents may experience a range of symptoms including elevated mood, increased energy, and impulsivity. However, in some cases, the manic episodes can escalate to include psychotic features such as delusions and hallucinations. Persecutory delusions, in particular, are quite common during manic episodes in adolescence. These delusions involve the belief that one is being targeted, harassed, or harmed by others. For example, an adolescent experiencing a manic episode might believe that people are plotting against them, or spying on them, or trying to harm them in some way. These persecutory delusions can be distressing and may lead to behaviors aimed at protecting oneself or retaliating against perceived threats. In options A, C, and D, those were incorrect. Option A suggests social withdrawal. Option C suggests apathy, and D suggests hypersomnia. Question 7. What is common among adolescents with major depressive disorder who are at the highest risk for bipolar I disorder? Is it A, lack of family history of bipolar disorder, B, chronic irritability, C, severe depressive episodes with psychosis, or D, excessive distractibility? The answer is C, severe depressive episodes with psychosis. So one key indicator that adolescents with MDD, major depressive disorder, might be at higher risk of developing bipolar I disorder is the presence of severe depressive episodes with psychosis. Psychosis refers to a break from reality which can manifest as hallucinations or delusions. In the context of severe depressive episodes, psychotic features might include hallucinations or of a depressive nature, or delusions of guilt, poverty, or illness. The presence of psychosis in depressive episodes suggests a more severe and potentially complex form of mood disorder, which could indicate an underlying vulnerability to bipolar disorder. And let's go over the incorrect. Option A was suggesting a lack of family history of bipolar disorder. Option B suggests chronic irritability. And option D suggests excessive distractibility. While family history can certainly be a risk factor for bipolar disorder, the absence of such a history wouldn't necessarily be common among adolescents with MDD at the highest risk for developing bipolar I disorder. And chronic irritability and excessive distractibility are symptoms that can occur in various mood and attention-related disorders, but are not specifically indicative of risk for bipolar I disorder among adolescents with MDD. Question 8. What is the key similarity between DSM-5 criteria for manic episodes in children and adults? A, presence of grandiose delusions, B, duration of mood episodes, C, age of onset, or D, type of hallucinations? Answer A, presence of grandiose delusions. Now, why is that? Well, grandiose delusions are a common feature of manic episodes across all age groups. Whether it's a child or an adult experiencing manic episodes, they may exhibit beliefs of grandiosity, such as feeling exceptionally powerful, talented, or important. These beliefs can be exaggerated and unrealistic, and they often contribute to elevated or expansive mood characteristics of mania. The presence of grandiose delusions is one of the criteria outlined in the DSM-5 for diagnosing manic episodes, regardless of the individual's age. So, whether you're assessing a child or adult, the presence of these grandiose beliefs would be considered a key similarity in the diagnostic criteria. And the incorrect ones, B, C, and D? Well, option B, that suggests the duration of mood episodes. Option C suggests the age of onset, and D suggests the type of hallucinations. While the duration of mood episodes and the age of onset may vary between children and adults with bipolar disorder, these factors aren't specifically mentioned as key similarities in the DSM-5 criteria for manic episodes. Similarly, the type of hallucination experienced during manic episodes can vary widely and may include auditory, visual, or other sensory experiences, but the presence of hallucinations isn't key necessarily in the similarities shown in the DSM-5 criteria for manic episodes across the age groups. Question 9. What is the significant difference between early onset bipolar disorder in prepubertal children and adolescents? Is it A, frequency of mood episodes, B, severity of temper tantrums, C, continuity with adult counterpart, or D, presence of ADHD symptoms? The answer is C, continuity with adult counterpart. Now, why is this significant? Well, if early onset bipolar disorder in prepubertal children has been a subject of debate and study in the field of psychiatry. One of the key questions has been whether the presentation of bipolar disorder in children is continuous with the adult form of the disorder. Research suggests that there is indeed continuity between early onset bipolar disorder and the adult counterpart. This means that the symptoms, course, and outcomes of bipolar disorder in children tend to resemble those seen in adults with the disorder. For example, children with early onset bipolar disorder often experience similar mood episodes such as manic, hypomanic, and depressive episodes as seen in adults. This continuity with the adult form of bipolar disorder is important for understanding the nature of the illness and guiding diagnosis and treatment approaches in children and adolescents. Now let's touch on the incorrect options. Option A suggests the frequency of mood episodes. Option B suggests the severity of temper tantrums. And option D suggests the presence of ADHD symptoms. While these factors may indeed vary between prepubertal children and adolescents with early onset bipolar disorder, they're not specifically cited as significant differences between the two groups in the context of continuity with adult counterpart. Question 10. What is a common challenge in managing adolescents with atypical bipolar disorder? Is it A, lack of mood dysregulation, B, low-level distractibility, C, minimal impairment in school, or D, severe impairment in school and at home? The answer is D, severe impairment in both home and school. Atypical bipolar disorders often present with symptoms that doesn't fit the classic manic depressive patterns seen in bipolar 1 or 2 disorders. This can make it diagnosing and management particularly challenging, especially in adolescents. One common challenge in managing these adolescents is the significant impairment they often experience in school and at home. Unlike some other adolescents who might struggle with occasional academic or behavioral issues, these types of atypical bipolar disorders can face severe and persistent difficulties that impact their functioning in multiple areas of life. At school, they may struggle with concentration, impulsivity, irritability, and erratic behaviors, which can lead to academic underachievement, conflicts with peers and teachers, and disciplinary issues. At home, they may have difficulty with the family relationships, chores, and daily routine due to mood swings, impulsivity, and emotional dysregulation. This severe impairment in both academic and home environments can significantly impact adolescents' overall well-being and quality of life, as well as pose challenges for caregivers and healthcare providers in developing effective treatment strategies. Now let's go over the incorrect ones. Option A was suggesting a lack of mood dysregulation. Option B suggests low levels of distractibility. And option C suggests minimal impact in school, all of which were incorrect. While these factors may be challenging in managing adolescents with bipolar disorder, they are not specifically characteristics of atypical bipolar disorder. In fact, adolescents with atypical bipolar disorder often exhibit significant mood dysregulation, distractibility, and impairment in school and home. Question 11. What percentage of prepubertal children diagnosed with bipolar disorder also have comorbid ADHD? Is it A, up to 20%, B, up to 50%, C, up to 70%, or D, up to 90%? The answer is D, up to 90%. Research suggests that a significant portion of prepubertal children diagnosed with bipolar disorder also meet the criteria for ADHD. In fact, some studies have been reported the comorbidity rate ranging from 60 to as high as 90%. Comorbid ADHD creates a significant source of diagnostic confusion in children with early onset bipolar disorder, since two disorders share many diagnostic criteria, including distractibility, hyperactivity, and talkativeness. Even when removing the overlapping symptoms from the diagnostic criteria count, a significant percentage of children with bipolar disorder continue to meet the full criteria for ADHD. This implies that both disorders with their distinct features are present in many cases. Question 12. What is the common comorbid condition among children and adolescents with bipolar disorder? Is it A, conduct disorder, B, panic disorder, C, schizophrenia, or D, obsessive compulsive disorder? The answer is B, panic disorder. So while comorbidity is quite common in mental health conditions, and bipolar disorder is no exception, when children and adolescents are diagnosed with bipolar disorder, it is not unusual for them to also experience other psychiatric disorders alongside. Panic disorder is one such condition that often seen in conjunction with bipolar disorder in children and adolescents. Panic disorders involve recurrent and unexpected panic attacks, which are sudden episodes of intense fear or discomfort accompanied by physical symptoms like rapid heartbeat, sweating, trembling, and shortness of breath. These panic attacks can be quite distressing and disruptive to quality of life. The co-occurrence of panic disorders and bipolar disorder can complicate the clinical picture and may require a comprehensive approach to assessment and treatment. It is important for healthcare providers to be aware of the potential for comorbidity and to address both conditions effectively. Question 13. What is reported as a higher risk among adults diagnosed with bipolar disorder and comorbid high levels of anxiety symptoms? Is it A, substance use disorder, B, eating disorder, C, obsessive compulsive disorder, or D, sleep disorders? Answer: A, substance use disorder. Now, why is this significant? Well, comorbidity is quite common in mental health conditions, and when individuals are dealing with multiple disorders simultaneously, it can complicate their overall health and well-being. Research has shown that individuals diagnosed with bipolar disorder often experience high levels of anxiety symptoms. Anxiety can manifest in several forms, such as generalized anxiety, panic disorder, or social anxiety disorder. When bipolar disorder coexists with high levels of anxiety symptoms, it can exacerbate the challenges individuals face. One significant consequence of this comorbidity is the increased risk of developing substance use disorder. Substance use disorders involves, of course, misuse of drugs and alcohol leading to significant impairment or distress. Individuals with bipolar disorder and comorbid high levels of anxiety symptoms may turn to substance use as a way to cope, to self-medicate, or to cope with their symptoms, which can ultimately worsen their overall functioning and prognosis. So addressing both bipolar disorder and anxiety symptoms, as well as substance use issues, is crucial for the effective management and treatment. The incorrect ones were B, C, and D. Option B and C and D, those all suggest other psychiatric conditions that can indeed coexist with bipolar disorder and high levels of anxiety symptoms, but they're not specifically cited as being reported as a higher risk in this context. Question 14. What is a significant predictor of more rapid cycling in bipolar disorder among children and adolescents? Is it A, higher socioeconomic status, B, presence of lifetime psychosis, C, bipolar 2 disorder, or D, bipolar 1 disorder? The answer is B, presence of lifetime psychosis. Now, why is that? Well, rapid cycling in bipolar disorder refers to experiencing 4 or more mood episodes, whether it's manic, hypomanic, depressive, or mixed, within a 12-month period. It's a challenging aspect of the disorder because it can lead to more frequent mood swings and often requires more intense treatment. Research has shown that the presence of psychosis during mood episodes is a significant predictor of more rapid cycling in bipolar disorder among children and adolescents. Psychosis involves a break from reality, which can manifest as a hallucination, delusion, or other distorted perceptions of reality. When psychosis occurs during mood episodes in bipolar disorder, it often indicates a more severe form of illness and is associated with poorer outcomes. So if a child or adolescent with bipolar disorder has experienced psychoses during their lifetime, it's a red flag for potentially more rapid cycling of mood episodes. This information is crucial for the treatment planning and prognosis. Question 15. What distinguishes the natural history of bipolar disorder in children compared to adults? A, higher stability of bipolar 2 diagnosis in youth. B, lower likelihood of rapid cycling in young children. C, increased rates of recovery in young children. Or D, higher rates of polarity changes in rapid cycling in young children. The answer is D. Now, why is that? Well, the natural course of bipolar disorder can vary between children and adults, and understand these differences is crucial for the accurate diagnosis and effective treatment. Polarity refers to shifts between mood states, such as switching from a manic or a hypomanic episode to a depressive episode, or vice versa. Rapid cycling, on the other hand, involves experiencing 4 or more mood episodes within a year period. Research suggests that children with bipolar disorder often experiences higher rates of polarity changes and rapid cycling compared to adults. This means that they may cycle through mood episodes more frequently and experience more abrupt shifts in mood compared to adults with the disorder. These rapid mood changes can have significant implications for children's functioning, behavior, and overall well-being. It can also pose challenges for clinicians in accurately diagnosing and managing this disorder. Question 16. Which of the 2 classes of medications are most well studied for efficacy in treating early onset bipolar disorder? Is it A, antidepressants and benzodiazepines, B, atypical antipsychotics and mood stabilizing agents, C, stimulants and anticonvulsants, D, antipsychotics and SSRIs? The answer is B, atypical antipsychotics and mood stabilizing agents. Now, why is that? Well, early onset bipolar disorder presents unique challenges in terms of diagnosis and treatment. Children and adolescents may have different symptom profiles and responses to medications compared to adults with bipolar disorder. Therefore, it's crucial to identify treatments that have been well studied and shown efficacious in this population. Atypical antipsychotics are often used to manage symptoms of mania, psychosis, and aggression in early onset bipolar disorder. These medications help stabilize mood and reduce the severity of manic symptoms. Mood stabilizing agents such as lithium and certain anticonvulsants like valproate and carbamazepine are commonly prescribed to help regulate mood and prevent mood episodes. Both classes of medications have been extensively studied in children and adolescents for bipolar disorder, and there's evidence to support their efficacy and safety in this population. While other classes of medications like antidepressants and stimulants may be used in some cases, they can be more controversial due to concerns about triggering a manic episode or exacerbating mood instability. Question 17. Which atypical antipsychotic was found to be superior in speed of its effect compared to valproate in recent trial? A. Olanzapine, B. Risperidone, C. Quetiapine, D. Aripiprazole. Answer C. Quetiapine. Now, why? Well, when treating bipolar disorder, especially manic in the acute phase or mixed episodes, the speed at which the medication starts to take effect is crucial for managing that patient's symptoms and preventing further escalation. There's a recent study that was done that showed quetiapine was found to be faster onset compared to valproate, which is commonly used for mood stabilizing. This means that quetiapine began to show therapeutic effects more quickly and therefore stabilize mood and reduce symptoms of mania and mixed episodes sooner than valproate. This finding also is important because it provides clinicians with valuable information when making treatment decisions for individuals. Question 18. In a trial comparing risperidone and sodium valproate treatment for bipolar disorder in youth, which medication showed more rapid improvement and a higher final reduction in manic symptoms? Is it A. Risperidone, B. Sodium valproate, C. Olanzapine, or D. Quetiapine? Answer A. Risperidone. So a trial was done comparing risperidone and sodium valproate for bipolar disorder in youth, and it was found that risperidone had a more rapid improvement and a higher final reduction in manic symptoms compared to sodium valproate. Question 19. What is the primary goal of adjunctive family-focused psychoeducational treatment for children and adolescents with bipolar disorder? Is it A, reducing manic symptoms, B, improving academic performance, C, reducing relapse, D, enhancing social skills? Answer is C, reducing relapse. Bipolar disorder is a chronic condition characterized by recurrent episodes of mania, hypomania, and depression. So relapse prevention is key aspect of managing bipolar disorder, especially for those vulnerable children and adolescents. Adjunct and family-focused psychoeducational treatment aims to involve family members in the treatment process and provide them with education and support to help manage the challenges associated with bipolar disorder. By educating families about the nature of the illness, identifying early signs of relapse, and teaching coping strategies, this approach seeks to reduce the likelihood of future mood episodes and improve overall outcomes. Reducing relapse rates is a primary goal because each episode of illness can have a significant consequence for the individual's function, relationships, and quality of life. Question 20. What significant improvement was observed in youth with bipolar disorder who underwent a year-long trial of modified family-focused treatment, high risk? A, improvement in academic performance only, B, reduction in manic episodes, symptoms only. C, improvement in mood disturbance, especially depressive mood and hypomania. Or D, reduction in medication dosage. The answer is C, improvement in mood disturbance, especially depressive mood and hypomania. Family-focused treatment, high risk, FFTHR, is a therapeutic intervention designed to address the unique needs of youth at high risk for bipolar disorder or those who have already been diagnosed. It typically involves psychoeducation, communication training, and problem-solving skills to help families better manage the challenges associated with bipolar disorder. The significant improvement observed in youth who underwent this intervention primarily focused on improvement in mood disturbance, particularly depressive mood and hypomania. This suggests that the interventions were effective in reducing the severity and frequency of mood episodes, enhancing mood stability, and improving overall well-being in these individuals. While other outcomes such as academic performance or medication dosage may also be important consideration in the treatment of bipolar disorder, the primary focus of this intervention and the observed significant improvement was on mood disturbance, making option C the correct answer. Question 21. What is the promising aspect of family-focused treatment for high-risk youth? Is it A, improvement in medication adherence, B, reduction in treatment costs, C, enhancement of family relationships, or D, deserves further investigation as a longitudinal follow-up to determine the course of youth at risk to develop bipolar disorder? The answer is option D. Now, why is it? Well, understand the long-term outcomes of interventions for high-risk youth is crucial for refining treatment approaches and improving outcomes in this population. Family-focused treatment aims to involve families in the treatment process and provide them with education support to help manage the challenges associated with bipolar disorder. It's considered promising for high-risk youth because it may help mitigate the risk factors and prevent or delay the onset of bipolar disorder. If you found this video helpful, go ahead and click on the next video on bipolar disorder and share it with a classmate as well. Thank you.